Okay, good afternoon, everyone. We are back in House Human Services. Excuse me. And this afternoon, we're going to be talking housing. And we appreciate having everyone in the room this afternoon, especially a Friday of Valentine's Day. So happy Valentine's Day, everyone. So we will do just a quick run around the room because we have lots of visitors, and so that you can see who around the table and where we were all from, because you'll have an opportunity to introduce yourselves as well. So my name is Teresa Wood. I am from Waterbury, and I also serve Bolton, Buell Score, and Huntington.
I am Ray Garofano. I serve Essex and Essex Junction. I am Jubilee McGill, and I represent Bridgeport, Middlebury, Haven, and Weybridge.
And I'm Esme Cole, and I represent Hartford.
My name is Zon Eastis. I represent Guilford and Vernon.
Doug Bishop, I represent Colchester's Chittenden 20 District.
Brenda Steady, East Milton, Westford.
Hi, good afternoon. I'm Dan Noyes. I represent Wolcott, Hyde Park, Johnson, and Belvedere.
Okay, and then we'll start here in this windowsill and go all the way around.
Sure, Natalie Flynn with Cathedral Square.
Karen Hanson, HCD.
Lindsay Thrall with Evernorth.
Elise Schanbacher, Addison Raleigh Works. Janet Claire with Washington County Mental Health and SACH.
Molly Dugan with Cathedral Square.
Keith Pillsbury, Denton Borough.
Kim Fitzgerald, Cathedral Square.
Holly Dawson, Cathedral Square.
Hi, my name is Amy. I presently am with the Family Center of Washington County and soon to be with the Memorial Housing Partnership through Dow Street next week. I'm Haley. I'm here in support.
Alex Rangel, I'm with Cathedral Square.
Jennifer Hunter with Cathedral Square. I do housing retention. Carolyn Dixon with Cathedral Square.
Reverse Committee Assistant.
Donna, I'm with Cathedral Square, SACH RN.
Is there anybody left at Cathedral Square? Okay, welcome here for Vermont Housing and Conservation Day. And thank you all for everything that you do for older Vermonters, people with disabilities, people, low-income individuals, and just the ability to have the fabric of our communities are much richer when people have safe and supportive housing to live in. So thank you for everything that you do. So this afternoon, we're going to be hearing from, is Molly and Kim going to both be? Okay.
I'm going to just do a quick intro.
Okay, great.
Then set them up with technology, hopefully. Good afternoon. For the record, my name is Molly Dugan. I'm with Cathedral Square, and today I have the hat on as I'm one of the co-chairs of the Vermont Housing and Conservation Coalition. We have 2 housing chairs and 2 conservation. So big, huge thank you to you all for letting us come in this afternoon to talk about how important the funds that you all have appropriated to the Vermont Housing and Conservation Board through the years has been and will be. And that's really what our message is here today, is that, we're this coalition of groups of 50 different organizations, large and small, not-for-profit, for-profit businesses, working in your communities and throughout the state on those dual goals of affordable housing and conservation. And, the coalition, to be clear, is asking you all to support the full statutory funding for the Vermont Housing and Conservation Board, which is currently in the governor's budget. It's $36.9 million. I also want to be very clear that this amount is not enough to meet the needs that we see in the housing side. You guys know better than a lot how dire the situation is for people to find housing. So we are, to be clear, looking for at least $40 million above the full statutory share on the housing side. That is what we're understanding from VHCB is the projects they have for housing in next fiscal year to be funded. So our members have a proven track record, which you're going to hear about as soon as I get out of here, And we have a pipeline of projects, and we're really going to focus with you all as the Human Services Committee, not just on the housing that we bring, but what we are doing and how we're using that housing as a platform to provide robust supports to keep our residents housed for as long as they want to be with us. So that's, you're gonna really get that from us today. So I'm going to turn it over to Kim and Jana on the SASH model and our mental health pilot. But first, I'm going to share the screen. Okay. You want to just advance yours?
Yeah. So good afternoon. For the record, I'm Kim Fitzgerald. I'm the CEO for Cathedral Square. And I wanted to just start by saying that Cathedral Square just opened our 28th community in Heinsberg. And that is due to the support of VHCD funding. And we have 2 other properties in the pipeline. We have a property we're working on in St. Albans, and we have a property up in Highgate we hope to build. And again, those 2 properties would not be, we would not be able to create them if we did not have the HCB funding. So I wanted to start there. But as Molly mentioned, we're here today to really talk about the services that we embed in the housing. So we have to have the housing first, and then we can layer in the services. So I'm going to give a quick overview of SASH and the history of SASH to kind of level set. And then I'm going to talk about a little bit of our results today, and then a little bit about new initiatives. And then I'm going to turn it over to Jana, who is joining us from Washington County Mental Health Services. So she'll start after me. So we're going to start with a little bit of the history. So back in the early 2000s, Cathedral Square opened the very first licensed assisted living in the state of Vermont. And although a great model, we did not know whether we could build enough assisted living to meet the aging needs of the demographics in Vermont. And so at that point, we had probably 700 residents living with us at that point, at least. And we thought, what are we going to do for all of the residents living in our independent housing if they do not have a Medicaid bed to go to as their service needs increase? We thought, oh gosh, we need to be part of the solution. And so we went to our Heidelberg residents and said to the residents there, will you help us create something that will help you be able to age safely in independent housing? And we had 75% of our residents raise their hand and say, we'll help you, which if you've ever done group organizing, that's huge, right? So very, very excited. And it's for them. It's for them. So we wanted to hear from them what they needed and what they wanted. At the same time, we went out to community partners and we said, we want you to be part of a design team helping us with this at the same time, parallel tracks. And we want to hear from you where you see the gaps in care. We don't want to duplicate anything you're doing, but we want to know where you see the holes, the gaps. And we kind of sense of us like as ice cream, like filling in the holes, right? So in that very first year, what the residents said to us is, I have to back up a little bit and say this: Cathedral Square has always been serviced enriched. That is our mission. That's who we are. So we always had a little bit of nursing at each of our communities, but the properties could only afford maybe an hour a week or so. And so the very first thing the residents said to us is, we want more nursing time. Having the nurse right on site where we live, somebody we know, somebody we trust. We can see them in the hallway. We can, very accessible. We want more nursing time. So that was one component. The other component is they wanted a care coordinator, somebody who knew all the services that are out there, knew what they were eligible for, knew what they weren't eligible for, who could be a coach and a guide. And so really that's what the seeds of SASH became. It was a full-time care coordinator, SASH coordinator as we call it, and a quarter-time or 10-hour-a-week wellness nurse. And we always intended to bring this to a population-based. So we talk about panels or groups of people. So 70 to 100 people is what we call a panel. And that equates that full-time SASH coordinator and quarter-time wellness nurse. And at the same time, the community partners said this would be great. And we also think that collaboration and partnership and talking about the participants together so that we're as efficient and effective as possible would be key to this. And so that is other very much a core component of the SASH model. So in that very first year at Heidelberg of bringing that care coordination and that wellness nursing on site, we saw the amount of times that the ambulance came to Heidelberg and brought folks to the emergency room drop significantly. So we were able to bring that data to Craig Jones, who was the Blueprint for Health Director at the time, the healthcare reform in Vermont, and tell him this. And he immediately got it and said, oh my gosh, you are in the home where the social determinants of health happen. You can make an impact. I want to add you to the Blueprint for Health for Vermont. And so in 2011, we were added, and under the MAPCP funding, that was a demonstration. And for the very first time, Medicare dollars flowed through to Vermont for SASH for those two positions. And it's the first time nonprofit housing received Medicare dollars. And so we were under the MAPC plan for the full time of the demonstration. And that took us actually to 2018 when that demonstration ended, and we went under the all payer model. And that is currently the way we receive our funding under the ACO, which is OneCare. In those early years, we were capped at 54 panels. And again, our panels are groups of people from 70 to 100 people. And so it's a little less than 5,000 participants across the state. And we chose just in 2022, actually, to use 2 years worth of the modest ACO increase we get every year to increase those panels because the need is great. There's been waiting lists. And so we were able to get 6 more half panels across the state. So we are now up to 57 panels across the state of Vermont. And we hope by the end of this year to be at 57 and a half. So that's a little bit, again, about our history. This gives you a map and a visual representation of where the housing hub sites for SASH are located. So we have 140 housing locations across the state. SASH is based at a nonprofit housing providers. And the one key component is when we receive that Medicare funding, they said, we don't want you to discriminate based on where people live. So we don't want you just serving people in congregate housing settings. We want you to serve people out in the community who have Medicare. So in addition to all of these yellow stars you see across the map, we also are serving participants out in the community around those stars. So we use the housing as the base that we can do programming from, and people can come to that housing. But we're serving, of course, people out in the field as well. And as I mentioned, the partnership is key. We partner with Home Health, nonprofit housing across the state. They're not all Cathedral Square housing communities, hospitals, mental health services, as well as other health providers. Really, again, very key component of the model. We like to show this picture to just show that the participant is in the driver's seat. That's very important for us. They're always at the center of everything we do. And so, really, again, it's that, just to recap, it's that SASH coordinator, it's that wellness nurse. It is that team that comes together to provide services as effectively and efficiently as possible. And then we have those panels or group of people. And we have just been able to add mental health clinicians, which you'll be able to hear Jana talk about in a little bit. So as part of the MAPCP funding, we had to be evaluated. So we had 5 years of rigorous evaluation by a national third-party evaluator. And what they found was that SASH was the only program they had seen that actually bent the cost curve. They said at the time they were lucky to see models or programs that broke even. I mean, even seeing that was remarkable. But to actually see the fact that we were able to lower Medicare expenditures was huge, and actually have some upwards of $1,400 per person per year. In addition, in that last evaluation, they were able to do a look into the Medicaid savings as well, and $400 per participant they saw just in the savings of living with us in independent housing for longer and not having to move into long-term care. So this is a quick profile of our SASH participants. First, we started out in 2009 at our Heidelberg site, and then we grew very, very quickly to almost 5,000 participants across the state. Our profile is very similar to what we see in our independent housing in that most are women, most are 65 and older, most are on Medicare, but we also have dual eligibility, almost a third, and we also have some Medicaid only. And that's because in our housing, we have young disabled. So that is why you have those. And we estimate that through our inception, we have served over 12,000 SASH participants through this time. Here's a little snapshot of the conditions of our participants. And so you'll see here the 3 top conditions are high blood pressure, osteoarthritis, and high cholesterol. Another thing I think is really important to pass out here is that national average is that folks who are on Medicare, 52% have 3 or more chronic conditions. SASH participants are 85% of our SASH participants have 3 or more chronic conditions. So we are serving a much higher need population. Also, 8 median chronic conditions is what our SASH participants. So again, huge, higher needs. Our age range here, as you can see, is 22 to 104, with our average age being 73. Here's a program. So again, we build on the SASH platform that we have in place and are able to build upon it. And because high blood pressure is our highest condition, with over 50% having high blood pressure, this is an area we wanted to focus in on. And we worked in partnership with the Vermont Department of Health. And as you'll see here in this slide, the orange and the red represent stage 1 and 2 of high blood pressure. You don't want to be in those categories, right? And so when we did this this program, we found almost 900 SASH participants who participated in the program had high blood pressure and they didn't know it. And so we were able to identify they had blood pressure, we were able to educate them, and we were able to get them diagnosed and treated. And then we were able to help them, manage their blood pressure. Now, I'm not a nurse, but I do know that this reduction in the systolic rate and the diastolic rate is huge and very rare to see. So very, very excited and proud of those results. And that's just over 3 years that we've seen that kind of reduction. So that's one of our initiatives. Another one is falls. As you may very well know in this committee that Vermonters fall a lot. We're nationally, we have a very high falls risk rate. And so we were also able to work with our participants to lower the amount of falls in the last 3 years. Now, granted, we don't want half of our SASH participants falling, but we're continuing to work in this direction and hope to bring that down. We do a falls risk assessment and we are in the home so we can see where, risk concerns can lay. So we do an assessment on each person individually each year to know what their care needs and wants and desires are. And then as our group, again, working in that whole group, those panels, we're able to look at all of the assessments. And then we're able to bring programming to that group of people in a very efficient way because we know what their care needs are. And so that's a big component, of course, of what we do is that group programming. In fact, last year we had over 2,000 participants participate in at least one of our programming events. Here's another initiative we've taken on. Again, this is building upon the housing platform that we have in place. So we found that we have half of our SASH participants have a dentist. The other half don't. And of those who do have a dentist, only 42% have actually gone to the dentist in the last year. And so we brought a dental hygienist on site. His name is Michael. And he was able to host dental clinics in 12 of our communities in 4 counties and performed over 100 cleanings. Yeah. And, we just have what we heard from our participants is that they were fearful. They didn't want to go to the dentist. They were embarrassed. They hadn't been for years. They were worried, like I said, it was going to be painful. And so having somebody come right on site took away all of the transportation woes, and they felt very comfortable and at home and at ease. And we actually have a story where a woman says, I am just praying for when Michael comes back to clean my teeth again. So definitely a success story. And again, we're very, very proud of that. But it just shows how we can kind of build upon what we have in place. I'm just going to call this out before I pass it over to Jana. We were the recipients of the 2024 iPro Quality Award in recognition of healthcare quality with Medicare participants. And with that, I'm going to pass it over to Jana, and then I will come back at the end.
I was going to say, just before you go,
Yes.
we might have a question or two.
Oh, I'm sorry.
Go ahead, Representative Cole.
Thank you. On this one, I'm curious how much collaboration exists with the open door clinics and in my district, it's like the Good Neighbor Health Clinic.
I'm not familiar with that, but we're always looking at whatever programs are in our communities. That's partly why we have regional oversight organizations, because then they know what's happening in each of their communities. And then they build upon those.
Okay.
Absolutely.
Yeah, I definitely think it'd be important to make sure they're connected.
Absolutely.
Yeah.
Yeah. No, thank you for bringing that up.
Thank you.
Yes.
Yeah, I think that's sort of building on it as not opposed to, but I guess in contrast to always thinking that you have to recreate something that exists in the community. But dental, I know, is one that there's insufficient access anywhere, honestly, in Vermont for lots of folks, never mind folks who maybe only have Medicare or Medicaid as their insurance.
Yeah. it's critically important as part of that partnership, and I didn't mention this, so it's a great question to remind me, is that we come together on a monthly basis with partners in the community to talk about our participants and how best to serve them. And we have confidentiality releases so that our participants are, willing to share their information so that we can talk and again, provide the best, most efficient services.
So we've also had quite a bit of testimony around food insecurity. And since these, I'm sorry, I didn't see.
No, I didn't raise my. Question. I know what you're gonna ask.
And the number of older Vermonters and people with disabilities living in situations where really they don't have sufficient access to nutritious food. And it's also, I think, been troubling to us to know that we have a large proportion of Vermonters, and a good chunk of them being people who are in your service area, who don't access SNAP benefits. And I'm sort of making this a goal of mine to increase the awareness of SNAP among older Vermonters and people with disabilities, and to reduce the stigma on accessing a benefit, and particularly for older Vermonters that, as a cash benefit. Trying to reduce the reliance on the food shelves and the money needed to go to the food bank and stuff when we have federal funds that are available to us for people to receive that benefit. So my question is, what kind of assistance do your SASH coordinators or nurses provide in helping people to know that benefit and apply for it?
Absolutely. I mean, that is the key component of a SASH coordinator, is to know about those types of benefits that are available and work with participants to sign up for them or to refer them to an agency to help them, depending on, what it is. For example, like Meals on Wheels, we work very closely with the agencies on aging to bring those in. We also work with bringing community meals to our sites as much as possible, as well, like family style, again, through the AAAs as well. But food insecurities is a huge component that we're always working with. I know some of our SASH coordinators are here, but and working with participants on, because we know that that's a huge concern across the state.
And Hunger Free Vermont coming and doing presentations, because they share that too. Like, people who are eligible are not taking a bit.
Right. So I'm just putting in the plug for all you folks sitting around who are around the table to sort of double down on that. That would be great. Thank you.
For a moment. Speak in my language, Teresa, as far as security and SNAP benefits. When I got into the field of aging over 20 years ago now, that was actually my specialty. And along the way, I keep emphasizing it. And I know our team also fields a lot of calls with if people are having distress with their benefits. They can't, like, something's going wrong with their EBT card, or they've never heard of it, or they didn't know how to apply. So it's something that we locally in Washington County are definitely really plugged in with. And we partner with the food bank to do some food box deliveries every month at some of our sites, and folks from other sites on our panel can come to those sites, as well as community members. So lots of partnering with those sites and the community meals sites and everything. Definitely at the top of our minds every day. I'm with Washington County Mental Health. I'm a clinical social worker and one of the newer SASH emotional wellness clinicians as we're rolling out this program that began in 2017. And we've still got Allison Miley up in Chittenden County, who was that original pilot clinician. And she's been able to support the rollout and consult with those of us around the state who are coming in. There's still hiring going on, but the funding has allowed for the rollout to 6 more parts of the state, designated agencies like mine. And, a few of the features we're able to, as Kim was talking about, meet people where they live. And I'll say that we can also see folks at our designated agency offices if they prefer to leave their homes and see us in an office. So I do that with some of the folks I see. We provide supportive therapy individually and groups. We can triage what's going on and kind of support referrals that are needed for care coordination. And that's sometimes to the SASH coordinator. Sometimes it could be to the area agency on aging or home health or another community organization. And we do lots of rich programs and groups, and I'll share a little bit more detail about that in a couple of minutes. So as an indicator of the growth of the program already, in 2024, we had 91 participants engaged for a total of 1,148 visits in that original area of the state where the pilot started. And over the past 3 years, since 2022, there's been an average of 50% of the male identifying participants at those two panels who have been participating, which is really exciting. Part of our mission is really to reduce the stigma of seeking mental health care, which we know is strong among many older adults. Slide
Can
13.
I ask a question?
Yeah.
There's this elder care clinician program
Yeah.
at the designated agencies.
Yeah.
That's been pretty much flat funded for a long time. How do you dovetail with that?
Yeah, so I'm actually a member of the elder care clinician team at Washington County Mental Health. And where there used to be 3 of them in the past across 3 counties, there's 1 now. They haven't been able to fill those positions. So they've had vacancies and they lost funding. But I meet with them with Paul Bezer in my region, in particular, and Mark Schmall. And they tend to serve the folks not enrolled in SASH panels, right? So when they get new referrals, if someone is at a SASH site, that referral is going to get directed to me instead of to Paul. But we do consult on a biweekly basis to kind of share similar issues and strategize together. And the same kinds of professional development that the elder care clinicians are receiving, we are as well. And I believe that's the same around the state. So we work very closely together and all part of the outpatient programs of those designated agencies. Although I will just mention too, quite a number of the folks at the SASH sites that I'm serving have also been receiving some services from the CSP programs of our designated agency. Okay, so we've got some keys to our success that I'll talk about. There's no billing requirements, so all of the services that I'm providing are free to participants. We don't have to worry about what insurance they have or don't have. And there's that like takes the complication out and it really reduces one of those barriers for folks. We have really flexible hours. I can see someone weekly, bi-weekly, once in a while when they need it, one time only. And we can schedule appointments during times that work for people in their own homes. We can do office hours. We're able to do telehealth, phone. There's so much flexibility. And as I mentioned, folks who want to get out of their home, and sometimes that's just because they want more privacy or they are getting out in the community anyways. I could see them at Washington County Mental Health facilities if that's what they prefer. So I think another huge key to our success is that we are part of these, interprofessional SASH teams. We work really closely with the coordinators and the wellness nurses, as well as our partners from other agencies. And that can include the folks from the designated agencies, the Council on Aging, Home Health, lots of organizations, senior centers. And I've really been impressed with the richness of that team collaboration and how it can really improve the lives of our SASH participants. Another key to success is the building of social connections that we see. We hear a lot about reducing isolation. And this work of bringing more group programming and emotional wellness group programming to folks is really helping foster some new relationships among neighbors. Sometimes people in congregate housing are just as isolated as people in rural Vermont. They might not know the folks who live down the hallway until there's an opportunity to come together. And in my case, I recently saw that there were neighbors who had lived in the same hallway for years, had never met each other, and they were just thrilled to realize that they were neighbors. So next slide, please. We've expanded the program through CDS funds, and that's an expansion to 20 panels across the state. And now it's active in 8 panels, including 2 in my region. So we're actively working with the DAs to hire and embed clinicians in 10 more panels. And for the DAs who are having challenges in employing clinicians, there's still vacancies. We've introduced an alternative option, which is an emotional wellness coach who does a lot of similar work, but they just don't offer therapy. They're not licensed to do that, but they do offer other kinds of supportive counseling and collaboration. So in the first year of receiving the expanded funding, 145 participants, or about 30% of the panels, have met with their SASH emotional wellness clinician. And we clinicians have logged close to 1,400 visits or touches with participants in our software during this period. And I'll mention there's a lot of those touches that don't make it into the software because they're in the hallway. They might not be someone formally enrolled in the program of SASH. All of the residents of the building can come to the events, can talk to me, can call me. It's really widely available. Let's see, next slide, please. So prior to expanding the program, SASH did a pre-implementation survey in 2023 to understand more about the barriers to mental health care that people identified. So you can see the reasons that people identified, and now I'm really confident that we're addressing these. Folks don't have long times to wait. We are typically following up within 3 days of a referral, and I'm usually seeing someone within a week of a referral coming in. Sometimes it's the next day or even on occasion the same day the referral comes in. And you compare that to sometimes people waiting years out in the community. It's really quite remarkable. As far as folks saying they don't know what help is out there, we're also providing a lot of rich referrals to other resources in the community for mental health and other resources that folks need. That cost barrier, I've already mentioned, we address that by providing free mental health care. And this worry about what others might think of me, that's in that last line there on the bottom. I'm witnessing as folks are showing up and participating in groups that they're discovering, wow, a lot of the people in my building or that are in this group, we share some of the same experiences, and that mutual aid that people experience really helps to relieve that fear or the worry of what other people think. They realize that they're actually sharing a lot in common. Next slide, please. So October 2024 marked our first year of the statewide expansion, and we're grateful to both Senator Sanders and Welch for endorsing the Congressional Directed Spending Awards. So we were funded to add clinicians to those 20 panels. And this data replicates our 7-year pilot up in Chittenden County, where 2 clinicians with Cathedral Square have their panels in Burlington. Next slide. So these are a few of the group topics that I've offered in Washington County this past year. And some of these have run multiple weeks. Some of them have been one-offs. And I tend to offer each group across as many of my 10 different sites as I can. So I'll alternate from month to month, and I'll kind of interweave different groups at different sites with occasions for open office hours where folks can just drop in informally and receive emotional support of one kind or another. And so I also put flyers up, and we have a newsletter where we announce these groups, and folks know that they can come to groups at other sites, not just their own. The last one in this list, understanding and overcoming negative and unhelpful thoughts, has been so popular at one of my sites that they asked me to come back and do more next month. So I'm getting ready to bring that back. And in closing on the next slide, forward it. I'm just going to share this story of one of our SASH participants. I'm going to call her Jane, although that's not really her name. So Jane loves reading. She's a regular diary keeper, and she cherishes memories of many friends and families who have passed away. She's been left with this feeling that she's alone in the world. That was a message that I heard really strongly when I was first getting to know her. She'd been in SASH for many years, and also had a history of engagement with her local senior center and her church. And for the past year, she's had bi-weekly individual therapy with me, as well as joined every single group program that I've offered in her site. Jane exhibited signs of having an intellectual disability, and historically she did participate in some of the state's training programs and sheltered workshops that used to exist. But for some reason, we haven't been able to get to the bottom of it. Her records were lost, and she wasn't served by the designated mental health agency in her region for decades. So as a result of our team's wraparound care that includes my work and a SASH coordinator and the wellness nurse, we've collaboratively been able to support Jane in building a larger team for her life that includes the Council on Aging case manager, home health and hospice, including some palliative care, her PCP office. She's been interested in having a guardian in her life again. So we've also been in touch with the Office of Public Guardian to pursue that, and other community supports, including bringing her librarian, who's helpful to her, into some of our conversations. So as a result of Jane's service from SASH and her group participation, she's also connected with new folks in her community. One of them's offered to help her with genealogy. One of them has mentioned that she would take her on a day trip in the summer to see a site of importance from her family history. She's really excited about this. And she looks forward to the group times far in advance and is always making sure they're on her calendar. She's also connected with a psychiatric nurse practitioner at her doctor's office and had my support to adjust to changes in her healthcare team and help her understand the roles that different people are playing. When she has to stress about all these names and roles, we're able to kind of sit down and review those to help her feel more at ease. And she is reflecting on her life's work, the jobs she held, the friendships that she has held, and feeling really increased pride and dignity in herself. And she knows that she's less alone in the world and that she deserves respect despite not having always experienced it. And I'm really grateful to be a part of the SASH team that makes a difference in the lives of people like Jane. And I'll pause there. That's nice.
Hey, great. Hi, everyone. I'm Elise Schanbacher. I'm the Executive Director at Addison Housing Works. We are the nonprofit developer, owner, and manager of affordable housing in Addison County. We have over 750 permanently affordable homes in our portfolio. Those include rental apartments, including 2 senior housing sites that also host SASH programs, which we love. We also have 9 manufactured housing communities with 340 homes in them. And then we also have homeownership opportunities. We have 76 shared equity, permanently affordable, single family homes and condos. As of 2013, we've been offering SASH. We actually have 1 full panel in Virgins and 2 half panels, 1 in Bristol at a senior housing site, and then 1 out in Shoreham and Orwell, where it's entirely community participants. So it's actually kind of a unique site. We haven't been able to develop housing out there, but we just recognized the need based on how isolated a lot of the seniors are who live out in that very rural part of Addison County. So I'm here today, as Molly said, first and foremost to request your support for funding VHCB at their full statutory share of 36.9 million. And also noting that that isn't going to go far enough to keep housing production just at the level of the last few years, let alone what we have in the pipeline as housing developers and what we need to do to generate the additional 30,000 homes that the state needs by 2030. So these are just a few of our properties. For those of you, just to sort of, situate yourself in geography sometimes is kind of nice. Top left, we've got North Pleasant Street in Middlebury, right in downtown Middlebury. We have the Firehouse Apartments in Bristol, which just opened in 2023, and then Virgins Community Apartments in Virgins. So we are one of the actually statistics that we just looked at recently as part of our strategic planning process that really struck with me is just how vulnerable the households are that we are serving. So we know that we've increased the number of families living in our housing who were formerly homeless, beginning in 2016 with the executive order that dedicated 15% of affordable housing units to formerly homeless. And then Act 81 from a couple years ago, bumping that up to 30%. So we've seen an increase from 15% to 22% just over the last few years in the number of our apartments that are dedicated to housing the homeless. So that's 80 families out of about 350 apartments. And that's still increasing. In 2025, 28% of apartments that turned over were leased up to individuals exiting homelessness through memorandum of understanding with John Grimm Housing and Services, Charter House, other coordinated entry providers in our area. The one that really struck me from our strategic planning process was just looking at the median income of our residents. So regardless of whether or not somebody is exiting homelessness, we know that half of the people who live in our apartments have qualified the extremely low income level, which is about $25,000 a year, which depending on household size, is roughly equivalent to the federal poverty level. So we are serving a population that really has a lot of need for wraparound supports and services to be successful in their housing. Additionally, 37% are elderly and 32% have a disability. And we absolutely would not be able to meet this need if we did not have funding from the Vermont Housing and Conservation Board. In addition to the funding that they provide for us to build the housing, they also provide about 5 to 10% annually, depending on the year, of our operating budget. And then new in 2025, they're actually funding a full-time resident services coordinator that for us is our second full-time outside the SASH program. So we've been able to expand and meet more need because of the HCB. So talking a little bit about the need for resident services, as I mentioned, there's an increasing need to serve more people exiting homelessness because of the huge increase in homelessness that we've seen in Vermont. Additionally, among our residents, we're also just seeing a higher acuity of mental health needs in that population. There's been a big uptick in substance use disorder as well, and just access to mental health services is still a challenge among our residents. There's also a growing body of evidence for using housing as a platform for health, delivering those services where people live, so that they're there when they need them. So in 2021, we launched our family support program that was entirely funded through local philanthropy. And then we were able to expand it this past year when the HCB received some foundation funding to support resident service coordinators for our family housing sites. So what our family support program does is it does focus on families with children who are at risk of eviction, but it can actually serve anyone living in Addison Housing Works housing. It's a little bit more intensive than the SASH program, even though we have a higher ratio of residents to family support coordinators than the typical 70 or 80 person SASH panel. These are coordinators who are able to address some issues that the SASH program can't. We have some folks in our senior housing who are also working with our family support program because they, we may have somebody who goes down from a dual income household, they lose a spouse, all of a sudden they're not sure how they're going to be able to pay their rent anymore. That SASH coordinator would probably immediately refer that person to our own resident services coordinator to start identifying community resources and what benefits that person might be eligible for and starting to help them to complete the paperwork to get into those services. So it's entirely voluntary. The resident signs a release that really allows us to coordinate with other providers in the community. So again, we're not wanting to duplicate what's out there. We just want to make sure that our residents, the statistic from that pre-study that Cathedral Square did about, 24%. I just don't know the services are out there, right? So that's really where we come in to make sure that people can make those connections to existing community resources. And then they can work with whoever they want. Maybe they had a falling out with a case manager from the local shelter, and so we're going to facilitate a relationship with Pathways or whoever it may be. The goal is to stabilize their housing and increase their well-being, both at the individual level and the community level. So when, somebody maybe is experiencing a mental health crisis in their apartment, that's going to start spilling over to their neighbors, right? So not only is it about stabilizing that resident, it's about making sure that the whole community sort of feels this response and knows that someone is there to make sure that the community has what it needs to thrive. It also fills a gap in upstream services. On paper, we have residents who may be eligible to get into a case management program with the local shelter. But when the shelter has to figure out on their back end if somebody who isn't literally homeless is going to be eligible for whatever pocket of money that they happen to have, or even if the person is eligible, but there's just limited funding in the face of the need, the shelter rightly is going to focus their attention on that person who's literally homeless. So that's sort of where we can come in, fill that gap, get to a person before they get so far behind in rent, for example, that they can't get caught up, or before they've had the crisis that leads them to, unplug all of their appliances and, overflow their sink or whatever it may be that actually ends up damaging the unit so irreparably that they would lose their housing. So we're trying to get in before that happens. So the impact of this program that we've also been measuring since 2021, I haven't had a chance to fully parse our 2024 data, but from 2023, we had 104 households with 68 children who participated in the program. That grew to 144 households with 94 children this past year when we added that second coordinator right around August. So immediately there was much more need among our residents. So the second person was able to meet. 96% of the people, and this again was from 2023, remained stably housed at the end of the year, which is actually roughly equivalent to our overall housing retention rate. So people who maybe experienced some kind of event that put them greatly at risk of eviction, then were in most cases able to cure and maintain their housing. The program also works with our manufactured housing community residents. In particular, the state's put out a lot of effort into programs like manufactured housing improvement and repair to help residents of manufactured housing in the wake of disasters with some flood recovery, or just to address weatherization or health and safety issues in their homes. The feedback from residents is that that's just an incredibly difficult program to access. Maybe they don't have an internet connection and can't get on to the portal to submit an application, or they need to get 3 estimates for the repair and they don't even know how to get started on getting estimates for a repair. There's income qualifications. They just assume they won't qualify, whatever it is. Our family support coordinator can come in, sit with them, do the application. And since that program started, I think actually we've just been tracking this since the beginning of 2020. Actually, not even the beginning of 2023, since midway through 2023. So over the last 18 months, that program has helped leverage $454,000 through MHIR and weatherization to help people make upgrades to their home so they have better housing in our manufactured housing communities.
Can I ask a quick question? So, this is starting to sound an awful lot like a community action agency. But we've been hearing, we've been delving into a lot about services and supports for people who are homeless, and I'm trying to understand the connection. So especially when I see things about rental support and access for weatherization and mobile home infrastructure and knowing that we have, the case management and service support in, frankly, lots of different agencies all over the state. I honestly am just trying to figure out if we're utilizing our resources the most effectively, since everybody has, we will all say we all have limited resources, and yet it seems like there's a lot of duplication happening. And I know everybody says we're working with our other community partners. That's kind of like the mantra that everybody says. And you just happen to be the person sitting in the chair right now. So that's why you're getting this question.
It's a fair question. I think there's a two-pronged answer. I think there's the world we live in answer and the perfect world answer, right? The world we live in, there just is not the capacity at the Community Action Agency to help the people who need help. Maybe if a resident even sort of like has the awareness that resource, they called 211 and 211 is going to get them connected up with the Community Action Agency. They're going to have to go to CBOEO from Starksboro to Middlebury, for example, for an appointment in like a week or two. It's not going to happen. Like, we're there to make sure that happens, that they get that take up, right? Take up of human services is a big part of the challenge. And I think that actually exists in the perfect world too. Like, even if CBOEO had all the funding in the world and all the housing case managers to help people do this, people still aren't necessarily going to make that connection, and especially not that early intervention, right? Because we're in the housing. We see the issue when somebody, has stopped paying their electric bill. We know, right? Because we're going into that apartment and the heat's not on or whatever. So that person may still not connect with CBOEO without that resident services coordination piece from the houser, who's the boots on the ground, can do that early intervention. The world we live in answer is just this example that's really stuck with me is we have so many people in our housing who are at risk of losing their housing because they cannot complete their Vermont State Housing Housing Authority paperwork, right? So they're at risk of losing their voucher. And we have somebody who was enrolled in case management services, so like eligible and actually connected with a case manager from one of our community partners. And we brought it to their attention that this person hadn't recertified and they were going to lose their voucher. And the case manager is like, I am so busy. Can't you guys just deal with this? So we do. And it makes sense too, because we already have all their income information in the file, right? So all we have to do is like bring some other information over to populate a 50058. And it is more efficient for us to actually just do that kind of work than referring it out. I would love if we could also get paid for it and not have to go to our local philanthropist to be like, hey, we're doing this vital work of keeping people housed, and we don't get funded the way that Pathways does, for example. So does that answer your question?
It does. It's the real world. I get that. I'm still just not sure it's the most efficient use of limited resources. But that's a question for another day. So,
Yeah.
I appreciate the fact that what you're doing is keeping people housed, and, because you are right there, that you see things earlier than maybe people sort of self-identify, because we all tend to think everything's okay until it's not. So I get it. We're really just struggling here, trying to have a system that makes some sense, and what are the best elements of the system to invest what finite resources that we have. And so it's helpful. Your background is very helpful, and hearing how you assist people through this is helpful.
Thanks. I would just say, we're already in those units. We already have those relationships, having worked at Addison Housing Works in the executive director role for the last 10 years and knowing how much we struggled to get people the help before we had somebody that our property manager can call over to Precious and our resident services departments and say, hey, I just talked to this person. They sound really like strange, right? Just like unwell, not themselves. Can you check on them? And then we have somebody can go check. It just isn't, it's not the same when that call is happening to an external partner who may not be able to get there a week or two or whatever it is. So I do really, really, really believe in it.
Yeah. And yet we also struggle with, hearing from the researchers that say, separating out the supportive services from the housers, the people who are providing the housing, is best practice. yeah, I see the value in there being a connection, it being I think that sort of rationale is based upon, there being sort of this dependency. If something goes awry and it's known because now this person is connected to the folks providing housing, that there maybe should be a little separation there, but I think there's pros and cons to both, I guess is what I'm saying.
Yeah, I think we, obviously, I'm biased. I think we do a pretty good job of managing, I think some of the built-in checks and balances, between the, firewall we have between our resident services team and our property managers. But also just because of the way that the program works, so much of it is at the level of our staff connecting with the staff at the shelter or the CAP agency or whoever it is, that I actually think it gives people more options of who they might work with, because we can connect them to so many different places in the community. It can work both ways. I've seen it play out both ways, where somebody no longer wants to engage with us, but now there's a service provider at the shelter who knows what's been going on because there's been a release and they've been communicated with from us over the last however long it's been going on. So they're better equipped to then take over. And I've seen it in the reverse, where somebody has just completely lost faith in the other service provider, like you have a bad experience with the designated agency, and guess what? It's the designated agency. There is no other designated agency. Yeah. And so we can then support people in that situation as well. I do also think there's a gap for, permanent supportive housing, right? There's a lot of research that permanent supportive housing really works and is effective, and the services are on site with the housing. I think that when we, the 4%, 96% are stably housed, the 4% can move on, really need a kind of housing that does not really exist in Vermont, and that's permanent supportive housing. But we're getting so much of the need right up to there, really. Other benefits, food security. We do community gardens. We do help with those SNAP forms. I was just in our database looking at, is actually the plurality of forms assistance was for SNAP forms, food shelf deliveries. There's you get those guys receiving greens that's from the CAP agency. We're like a delivery site. We're able to receive fresh food from the CAP agency because we have a staff person and a refrigerator. And so they don't just, sit on a table and spoil or whatever. And then community building, that's sort of more on the prevention side as well, right? We're hosting that Halloween party so the kids get to know each other, or the people who live down the hall can make that connection. We have a DREAM program at a couple of our properties in Middlebury. That's the program that comes in and provides summer camp, and then also ongoing mentoring during the school year, connects them with college kids at Middlebury College. We've had some literacy initiatives brought into our housing that our resident service coordinators are, to get into the weeds, right? The literacy initiative person's going to call me up and be like, hey, can we do this? And if I don't have a staff person to pass that ball to, it's not going to happen, right? So our resident services staff are providing that capacity to make sure that we can do the community building activities and take advantage of all the resources and all the other great things that are going on in the community, and make sure that our residents have access to that. I didn't put this slide in because it's a little outdated, but just a quick story of back during maybe it was the Blueprint for Health era, but we had a blueprint coordinator in Addison County who was also very data minded. We did a sort of an anonymized, based on all of Addison Housing Works addresses. She ran them through her Medicaid claims data. And so we had a control group of non-Addison Housing Works, so non-affordable housing resident Medicaid recipients and affordable housing resident Medicaid recipients. And all of those things that Kim was talking about, the co-occurring mental health and physical health issues were higher. Even though it's two groups of Medicaid recipients, we are serving a more vulnerable population. It's like 2/3 of our residents have 2 or more co-occurring mental health issues. And so I do think it's really important to have a structure that brings the resources to the affordable housing properties where people are more likely to be disadvantaged and not have access to those resources otherwise. And I'm missing a Valentine's Day party right now that our family is putting on in Pleasant Hills with our SAF coordinator at Pleasant Hills as well right now. Which is, they do lots of intergenerational stuff. I had a photo up there earlier of Verdun's Community Apartments, which is family housing, but it's right across the street from our senior housing SAF site at Armory Lane. So they've done kids make Valentines for the seniors, or the kids come trick or treating. The seniors were actually during the pandemic, because they have this huge, gorgeous wraparound porch. The seniors came out on the porch and the kids went trick or treating around the porch. This one that's going on right now in Bristol, the chorus from Mount Abe High School is going to sing for the seniors at this Valentine's Day party that's happening right now. So it's just forming really nice community connections and partnerships.
Great.
And that's really it. I'll just close reiterating that note on, please and thank you for supporting the base funding for VHCB at 36.9 million. And there's a lot more to do. We know there's at least 40 million additional projects in the pipeline just through FY26. And that funding is so critical to having the housing, and then just supporting VHCB has that extra layer of us existing at all and being able to provide the resident services and do this. So thank you.
Thank you very much.
Thank you.
Did you have a question, Esme?
Yeah,
Oh, no, you, please, go first.
Oh.
I might be long-winded.
oh, okay, so yeah, I know.
Actually, you need to be recognized in order to speak. Sorry.
So I know we're over time here, but I recognize that Addison County is one of our largest, densest farm counties in the state. And so I know, VHCB has several programs going for the farm worker housing. I'm curious if Addison Housing works in tandem with them or separately, or.
So we will refer up to Champlain Housing Trust. So as a VHCB grantee, we're definitely in the loop on everything that VHCB is doing with farm workers. Champlain Housing Trust is the entity that's administering the farm worker housing funding. And they've done a lot of the first tranche of funds have gone to Addison County through Champlain Housing.
Oh, nice. So it's kind of separate. You just get referrals.
Yeah, we'll refer up to
Okay.
CHC.
Thank you.
Any other questions for this witness or any of the witnesses this afternoon? Thank you.
Thank you.
Well,
Thank you so much.
Kim, I didn't know, you said you were going to come back up.
You had asked, so I'll just say this quickly, you had asked for comment on H91. So we aren't experts on the shelter housing side, of course, but that is a stepping stone to come to permanent affordable housing. And so in reading the bill, I just have 3 very quick comments because you asked. The first is that you use the term congregate. And as you heard in my testimony, we do that with housing as well. We say congregate housing, meaning multi people living in the housing. So I would recommend that you define it as part of the definition. So that would be 1. 2, I absolutely support the coordinated entry piece as absolutely critically important. I know that around the state, people have varying levels of support with their coordinated entries. We happen to have a very good relationship with our coordinated entry and works very well. And then 3rd, robust reporting is really, really important, and we agree and support that. So just wanted to give you those.
Thank you.
Yeah.
Just around individuals exiting hotel program or homelessness who are living in hotels. Do you interact with the program to try to help find them housing?
So, and this could be a whole presentation, but I want to say, so it's similar to what Elise was saying. We, Cathedral Square, currently house over 200 people who are formerly homeless. And we do absolutely work with coordinated entry to try to find them housing and to also find the best, most suitable housing for them, right? Because one size doesn't fit all, right? So for some people, congregate living where you have to go through a open corridor and it's shared, like a corridor to get to your apartment might not be the best, suiting for you. We have apartments that have private entrances. That might be a better location. Again, letting people know what those options are is really, really important so that you can get the right fit. I give a quick story. We had a resident who lived at one of our communities who in the middle of the night would wake up screaming, at the top of her lungs, all of her neighbors being affected, not being able to sleep, affecting their health. And this woman did not realize that this was happening in the middle of the night. This is quite a few years ago. And she was on the verge of eviction over a lot of time that was working with her. And we said to her, we have a community that is concrete walls. It's concrete walls. Would you be willing to move there and try that? She has lived successfully at that community for the last 20 years. So it's about finding the right fit. And again, one size doesn't fit all. But services are critically important, right? So there's two components, not only the services, but also the Section 8 subsidy, because residents cannot afford to live, even in the tax credit apartments, they can't afford the rent. They need that Section 8 subsidy to be successful. And we're actually setting them up for failure if we put them in permanent housing without that Section 8 voucher and without support services. I have two staff here right now who we are doing a program that we call HIP, which is a housing incentive program. We're actually providing incentives to those who are exiting homelessness to incentivize them to partake with services and with our staff. And they get a cash incentive each month, and then half the money goes in the bank, half the money goes to them. And if they're successful, we know those first few months are critically important when you're living in congregate housing. It can either make or break your residence when you're first meeting your neighbors and whatnot, but it's a 5-year program. So then we jump to a year incentive, a 2-year incentive, 3-year, and then by year 5, if you have successfully had tenancy for that entire time, you get everything in the bank account for you. So it's the total cost of incentives the person could glean from this program is $3,750. And we already have six people enrolled currently. We're already giving out those incentives on a monthly basis and already seeing huge success. In fact, I got to share this one story if I could, because it's really impactful.
Incentives.
We had a gentleman who was homeless, came to us, and Carolyn, correct me if I get any of these details wrong, but was homeless for about a year, living in and out of his car. He came as living in one of our communities. He has joined our HIP program. And he heard somebody struggling outside, and he went out and realized that he needed the Heimlich maneuver, and the person who was chest compression, and somebody was doing it wrong. He stepped in, he saved their life. So these are our neighbors, these are our friends. I know I do the same thing, and it's critically important that we support them, but support them in the right way.
Just a quick follow-up. What's your capacity in that program? And what would it take to?
So we want to expand it. Our goal right now is we have enough to support 20 participants, and we would like to expand that to at least 60. And we are working with trying to raise funds, and it's all private kind of fundraising that we're doing right now for it. It's amazing how many people will not support the incentives.
Are those names coming off of the coordinated entry
Yes.
list? Okay,
Yes.
so they're.
Yes.
Thank you.
They have to really pretty much come off that to be part of our.
Just one quick last question. What's your waiting list for housing?
For housing in general?
Yeah.
So we have 1,100 units of housing, and we have a wait list of over 1,100. And it's taken, we're 47 years old. We could build tomorrow what it's taken us 47 years to build and not meet the need that we're seeing today.
Thank you.
All right. Thank you very much, everyone. Appreciate everyone being here this afternoon, and appreciate the successes that you're having and the innovation and, trying to figure out the best way to support people where they are. And I think that is just a critical message for all of us, that is kind of one of the key things that breeds success, is when you're able to meet people where they are in that moment in time. So thank you all for being here. Thank you for sticking it out on a Friday afternoon. Really appreciate it, and have a great weekend.
Thank you. Thank you.
Thank you.
Think about that in
Oh, yeah.
Yeah.
Except I want to add it's purple 23.
Hi, what is that? Oh.
Don't close the door. we-
Yeah, come in and close the door.
Thank you.
Okay, so just in the next 15 minutes or so, I just wanted to do a check-in with people about how your budget work is going, about whether you're encountering any difficulty getting information, or if you need any assistance from me in accessing information or questions. Yeah. So why don't we start with DCF to my left in child development?
Yes, thank you, Madam Chair. So Representative Bishop and I have the Child Development Division portion of the DCF budget. And as we heard from the department, the two big things in that area are the caseload savings and CCFAP and the anticipated additional funding that's coming in from the payroll contribution. So we are working with our JFO colleagues to figure out details on that and what its impact is on the base budget versus a one-time reduction. So we're hoping to get confirmation about that early next week. We've also had several requests from community partners, community organizations that work in early childhood education. And we've been meeting with those individuals and organizations, digging deep into their requests, getting more information and clarifying some of the asks. So I hope to wrap everything up next week. So I don't want to kind of go into details of what those requests are yet. And then lastly, we did meet with the department, had a really productive meeting with them. They kind of shared some of the things that either in the midst of that they're working on as far as meeting federal requirements that they need to be in compliance with like early next year or soon-ish. So that is going to help inform some of our decision making as far as recommendations.
Okay, and so I'm going to ask this of each group, so just be prepared. Is there, while we don't have time in committee to hear from all of the entities and organizations that are, wanting money from us or wanting us to make our recommendations to appropriations, sometimes there are things that are wide-reaching enough and big enough that the full committee should hear and not just the team. Think about that. We can come back to you if you want, but think about that because that's obviously it's an agenda buster. So we probably wouldn't be doing that next week, but we would try to fit them in early in the following week. So if you think that there is something that's wide-reaching enough, in your update, let me know. Okay, thank you. Why don't we just go around the table with economic services and OEO?
Sure. So we were working through some of the lineups today, Julie and I, and we have we're scheduling an appointment with the Lake Sojourner to ask a few questions next week. So 211 is something that we're going to be addressing, the food bank appropriation, learning more.
Excuse me, just on the food bank.
Oh, yes.
There is, so there's like a triple three-part request.
Yeah.
We're not going to deal with the food bank. They're going to deal with it in ag.
Okay.
Okay. So what we will need to do is to just make sure we know what ag is going to do. And then you can let us know if we should be supporting ag's position on that.
Cool. Yeah, we weren't sure if we were responsible for just a segment of it or.
Exactly.
Yeah.
Yes, I clarified that with the lobbyists and so, yeah.
Cool. So we will continue talking about that. And then of course, GA funds and a lot of questions about how those will be, I guess starting off with GA support services. So there was a reduction there. But we think it's because of lack of utilization and lack of information about those support services that are offered. So if they really aren't being used for whatever reason, then we're asking that the department either ups the education and make sure that folks utilizing the program know that it's available service, or if they don't see that as the best fit, then some of these are medical funds or stipends that can be used to help pay for medical services. So asking if that money can be, instead of just going away, go to like our open door clinics or somewhere else where these folks could receive medical care. So it's still going where it should go. And EBT stuff, Free Square stuff is mostly federal. So that's mostly dealt with, but we might have a couple of questions based on caseload pressures.
Would you be willing to ask around the SNAP stuff? So we were made aware that there is a abbreviated form that's available for some individuals, but it's not easily found on their website, and it's definitely not fill outable on their website.
Abbreviated form.
Yeah, I'll send you a copy. I got, Carrie Stoller sent me a copy of it.
Okay,
So I'll send you a copy of it.
so that's not on there.
Well, it's not easily accessible. Let's just put it that way.
Okay,
And it's only like, if you happen to know that there's this
Yeah.
process.
okay, good to know. We'll add that to our questions. And yeah, so REACH-up caseload adjustment was another biggie that we wanted to ask about, and we only got the low end of their projections listed in the budget adjustment, so we want to know what the consultant's high end projections were to be safe, to be well informed. And then a lot of questions about GA, like, for example, which shelters are going to receive that money? Are they shelters that are being utilized? Who's staffing those shelters? Is it out of state contract or not? I have a lot of questions about how that money, that's within HOP, apologies, not, GA. So these are some of the questions we have.
Okay. Are you doing okay with in terms of getting responses in time from the department?
Yeah,
Okay.
I think so.
Yeah.
Yeah,
All right, so just as a reminder, folks, the 26th is when we have to have our recommendations to appropriations. So we're kind of like back planning from there. So 26. Yeah.
Okay.
Okay, let's move to the health department.
Okay, well, so we only have just a few questions actually that we're looking at. One is just to learn what it is, and you might be able to just explain it really quickly, and that's in section 311, B311, what the fee for space charge is, and what that's about. It's a little over $500,000. Just
It literally is what it is.
just-
It's rent.
okay, so and they.
Every state department has it. It's
It's just
the
like,
Department of Buildings and General Services
okay.
owns all the buildings, and every
It just-
department has to pay rent to.
I see, so it's like, it's sort of like the IT charges as
It's
well.
exactly like that.
Okay,
yeah.
So it's just, so that's one off the list then.
Yeah, you can take that. They have no control over it. It's just a bill they get sent every
Okay,
year.
good. All right. We just weren't sure. So then the other one is the opioid abatement plan. There's money taken out of this budget, a little over $1 million, but there's another plan coming elsewhere.
218.
Yeah. So is that will that come under, is that Department of Health then as well?
The Department of Health asked for the opioid abatement settlement fund
Right.
recommendations to go separately in a separate bill. And so,
Yes.
I introduced a bill with that, that's 218.
Okay, well,
We're gonna get a walkthrough of that on Tuesday. And, so that will go concurrently with that. And since it's a separate bill, we'll take testimony on it.
okay,
And that will be, for instance, one that the whole committee listens to.
yeah, okay.
It's budget, but it's also a separate bill.
Okay, we wondered how it would sit. Okay, great. Then the other issue that seems to be something of, we're going to be talking with Tiff, and Dr. Levine, we hope, about this pilot recovery campus.
Yes, a lot more information needed about that.
Yeah, it seems like a completely crazy number to think about for this budget. If what the plans that we've heard about are real, this doesn't seem to be supportive of it. So in the right kinds of way. So
It would be great to get a lot more detail about what that really means.
Yeah,
And
okay.
if they have something specifically in writing about that, other than, that brief description that was in there.
yeah, okay, yeah. So yeah, that's on our plan.
Right.
Okay, and that's it for us.
Great. And this is just a reminder about checking the language sections of the bill as
Mhm.
well, making sure that there's if there's any language, or if you have language that you are going to be proposing, that's something to be working with Katie on. So if you have
Okay.
recommendations
That's
about
it.
things that you want.
That's level to come at this point. for
Okay.
us, Yeah.
Okay. So then the Todd and Dan show
Sure.
with Dale.
So, as you know, there's not a lot of increase for home and community-based providers. And we've met with them. They've actually all come together through this long-term care coalition that you talked about possibly having someone in, and that might be a good group to really understand the severity of where things are in home and community-based providers with the level funding. We reviewed back last year on the recommendations that we made, that Ray and I made to the committee, that we made to the appropriations committee, and are looking at what was implemented there, because we referenced a lot of kind of a 3-year plan to kind of bring them up. And so we're working through that. We've got meetings early next week with the commissioner to just talk about where some of the thoughts are around like skilled nursing facility. They're want to make sure that the caseload increase that they've budgeted for is not going to end up needing more in a budget adjustment like we saw before, because they do have it in there, but it's got some questions around it compared to last year, because it's not, I mean, there's more this year.
Is it
which
comparable to
good.
the levels that they're through budget adjustment that they're asking for
Yes.
this year in 25?
Yeah.
Okay, so I would love to make sure that we focus in on completing what we started 2 years ago on the
Mhm.
rate study report.
Yep.
So there are things
Which
in
is
there.
pretty much what that group is asking for. They're looking at the rate study and, getting it to implementation.
And then the second piece would be and you probably already thought about this, but working with Nolan and JFO on what we sort of typically put out there, and that's needing to calculate with the respective departments what each 1% would be in a inflationary adjustment. And I'm sure that it is something that in working with Representative Yakavoni, he may just check in with him, maybe something he's already asked for, I don't know.
Yeah.
But if he hasn't, then we should work with him and make sure that we're asking for the same thing, but Nolan will.
Yep.
It's
Just update that.
it's an update from
It's
last
an
year,
update from
essentially,
last
yeah.
year, which would be good to have as we make the recommendations.
Yeah.
And then, last year we did some DS also. So we need to look into that.
Are you talking about housing?
No. DS caseload.
Oh, yeah, that's an annual thing.
Correct.
Mhm. Okay, and just as an FYI, they're gonna deal with the DD Housing Initiative request downstairs in House General.
Okay, perfect. That's it.
Okay, all right, great. Up to you, we're at DCF Family Services.
This is my first time, and Rep Donahue is a pro and so good at this. So I wasn't sure what I was gonna do, so I just, during my break, I wrote down a few things that we've been working on. Identifying the expectation for the FY 26 budget presentation that accounts for what we were paying per year to run Woodside and where the money is going now, including exactly what it has been and is being spent on Red Clover. So that's one area. Another area we worked on is meeting with Erica and Megan regarding specific areas, including discussion of the funding flow regarding youth detention facilities. And Representative Donahue specifically asked for a report on the shackles, that it's something used to happen years ago.
Okay.
So, and there used to be an annual report, so she asked for an update on that. The transportation increases, which are happening all over Vermont right now. We checked in with that. We met with representatives for the Vermont Network regarding supervised visits. And there's areas that's not getting any. And some of them, in 2023, the last study, 61% of supervised referrals came from court. 29% came from child protection, and where they're lacking is people to go meet with people in need to visit their child that they would like to visit. And in some cases, it's not happening because there's no
There's no
place
supervision, yeah.
there's no safe place for
Yeah.
it to happen. This is all new to me. So Anne is checking into the funding source part and speaking with another person, is a representative in another area. Is it housing maybe?
Oh, judiciary, maybe.
Who's the name?
Lalonde,
No,
no?
and then,
Sorry, okay.
well, she's meeting with another committee to see that part of it. And Anne is following up with the information regarding the funding source because they got it from one source, and that source is no longer it is judiciary. It's no longer gonna be giving that source of funding, so Anne's working on where that source of funding is, because it's such an important need for a parent or grandparent, somebody to visit.
So one of the things,
Tell me what to write.
one of the things to investigate, and this, you might need JFO's help on this, is that there is still some CHINS reform money left from several years ago, and Ann will know what that means.
Okay.
And so will Nolan, JFO. And that might be an appropriate source because these are related to child custody cases, essentially. That might be an appropriate source of funding for that visitation.
Thanks.
You're welcome.
Very helpful. How did I do my first?
Everybody did great. So it seems as though you're getting access to the information you need. If there's any barriers that come up in the next week, we're going to do another check-in next week to see how things are going. So far, I heard potentially the Long-Term Care Crisis Coalition, which I'm sure we've all gotten the handout that right here, right? If they, I mean, we've heard from some of them sort of individually. We've heard from designated agencies, we've heard from the home health agencies, we heard, you know, and they are looking at things as a total package. So, I guess I'll leave that up to you, Dan, to decide if they have one rep that they want to,
I think they,
you know, send us off with a consolidated message.
Yeah.
And then, potentially, maybe week after next, on our oversight and accountability, we'll look at Act 76 and we can combine that with some budget questions at the same time. Because that's another sort of big area where governor's budget shifts a bunch of money. I think the health department will be the biggest thing is this new campus thing and really understanding that. And then H218, which will be making sure that we have some agreement about those investments. And obviously, we're going to have continued work on the GA emergency housing issues in particular. All right, folks, that seems like a good place to stop. We have a ton of testimony next week on H91. We'll have a introduction to H218, which is the opioid abatement settlement funding bill. And then you will have some more limited time, like either before or after floor time in a couple of days to, you'll see it says committee discussion, but it'll be a combination of committee discussion and work time for you on the budget stuff. We should be prepared by the end of next week to have the grid that what's your name? Ray. That Ray. The grid that we use for budget adjustment, we're going to use for the budget as well. So remember, you're going to need your B numbers and descriptions. So you should be prepared by the end of next week to have a draft of that. Okay. And then we'll finalize our recommendations the beginning part of the following week. Any questions?
Just,
Yeah.
could you go back to that where you said next week you'll have, it says committee discussion time.
Yeah.
We can schedule.
Yes,
in
you can
those
schedule
times.
in time. Yes.
Perfect. Thank you.
You're welcome.
Just wanted to make sure.
Yeah.
We're trying to set some times up and that's
Yeah.
helpful.
Yep. And if there's, if your contacts at the department have you like, oh, this is the only time I can meet with you, and it happens to be time that we're taking testimony on 91, as long as we don't have, like 2 or 3 teams out at the same time, that's okay. Okay.
Mhm.
All right. I think that's it, folks, unless there's any other questions. Thanks for a good week. You want to give a little update on H13 and what happened with that?
Yeah, I'd like to hear.
Yeah, so I went to appropriations yesterday with Jen Carby from Ledge Council, Nolan Langwell from JFO. We ran through the bill with the committee. Nolan let them know that there was no cost to the state. They had a couple questions, and they voted 10-0-1. Missing one of the representatives was not there to move it out of committee, and so we'll be back on notice today for action on Tuesday.
So Dan will be working this weekend, doing his floor report.
Actually, I'm writing a grant this weekend.
Oh.
Yes.
Dan's doing a lot of work this week. He thought he was going skiing, but, so that's important. That's going to be our first bill on the floor on Tuesday. Okay. So it is very important that we are all on the floor to support our committee member. And just as a reminder, and for people who haven't been through this before, we don't interrogate our own committee members. So that's what we do here in the committee.
I heard it.
Okay. So I don't anticipate there really isn't the reason for a roll call on this. But we want to move it through to the Senate as quickly as possible because it's really important. So